Keep your best years ahead. Longevity Roadmap with Dr. Buck Joffrey.
Welcome back to Longevity Roadmap. This is Buck Joffrey, and today what we're going to do actually is similar to what we did last week. I'm just having a lot of fun with these one-on-one coaching things that I'm doing for people who buy the Longevity Roadmap course, which again, I encourage you to check out. Go to longevityroadmap.com. I just think it's so fascinating to me. You know, obviously I micromanage my own health and all the things I do, but you know, this has really given me a chance to look at what other people who are actually in the longevity space who are interested in doing things to optimize themselves, the kind of situations they're in. It's been pretty rewarding to be able to, you know, what I think is to help people potentially live a longer and healthier life, both lifespan and health span related. So I want to tell you about something else that came up. And again, completely anonymous client here, 48-year-old guy, healthy, ex-athlete, and no significant conditions really, you know, no real health problems or anything. He's on some testosterone replacement. Notably, as a father who underwent bypass surgery in his late 60s, though. So anyway, what I really want to focus on with this guy is the fact that he is very lucky because he got some labs that if you look on the surface, most physicians wouldn't even wink an eye. So let's talk about his lipids for a second. So his LDL cholesterol, okay? And again, when you go to your physician, this is typically what you're going to get. You're going to get an LDL, you're going to need, you know, you're going to get an HDL, you're going to get triglycerides. You're not going to get a whole lot more than that, okay? But his LDL cholesterol is 110. Now, most physicians are going to say, well, you know, traditional threshold here is about, you know, to keep it under 130 milligrams per deciliter for normal adults, you know, haven't had any heart disease of any kind in the past, all that, right? So he's sitting at 110, obviously less than 130. So right off the bat, it's like, no, that looks fine, right? Then his triglycerides, they're 154. Well, again, the interpretation there might be from your traditional physician looking at these, or any physician necessarily looking at these, hey, they're slightly elevated, but not alarming. I think most physicians would conclude that this person isn't at significant cardiovascular risk. And I wouldn't necessarily blame them because, again, this is kind of what we learned in medical school. Now, as you know, we kind of look a little bit deeper than that because what we know is that specifically when it comes to LDL cholesterol, what does LDL cholesterol tell you? Well, it gives you sort of an absolute number when it comes to cholesterol, but it doesn't really tell you the kinds of particles that are in your bloodstream that end up being probably more important. So if we talk about like the two major factors, if you come together and talk about what causes cardiovascular disease, causes what we call atherosclerosis or narrowing of blood vessels. As a review, there's really two things here, right? There is inflammation, systemic inflammation, low-grade inflammation, and elevated cholesterol particles. Those are the two things that we know that really are involved with the development of cardiovascular disease. Now, inflammation is also, you know, inflammation is kind of a broad topic, right? You can have inflammation from a lot of things, from smoking cigarettes, from high blood pressure, so on and so forth. But the point is, when we look at the lipids here, it's important to understand what it is that we're looking at, okay? And that's where the missing link comes in. And that is this variable that we call APO lipoprotein B, or APO-B for short. Why is apolipoprotein B important? Well, APO-B is a protein that's found on the surface of all atherogenic lipoprotein particles. So yes, it counts LDL, but it also counts VLDL, and it also counts something called lipoprotein little a. And Most notably, when you talk about a number for ApoB, it's not telling you how much cholesterol it is. It's telling you how many individual particles there is that can create a problem for you, because it's the number of these so-called atherogenic particles that matters, not necessarily the total amount of cholesterol that you get a reading from when you measure LDL cholesterol. So you go in the blood vessels, each one of these, the more of these atherogenic particles you have, the higher risk you have of them getting into the walls of your blood vessels, and then, this inflammatory response happening and you developing cardiovascular disease. Okay. So in summary, LDL is really telling you the total cholesterol absolute number. ApoB is telling you the number of dangerous particles that could cause disease. So that's why ApoB is a more important, useful number for us to know about than LDL. Okay. ApoB also includes triglycerides in that as well. So in this person, the result for ApoB, the number that he had was 101 milligrams per deciliter. Now, a traditional cardiologist is going to target less than 90 milligrams per deciliter for higher risk patients. And so in that regard, many would say that this is just a mildly elevated number, which, it is. Like if there's nothing else going on here, you look at that, it's not where I would want mine, because I believe in targeting around 60 or less milligrams per deciliter of ApoB. But 101 in a otherwise healthy person would not be a huge deal. Okay. But here's the kicker. And this is something that I can guarantee you less than 10% of people out there, when they're getting their blood tests, are getting this test, and is for something called lipoprotein little a, like, not capital A, but little a. So lipoprotein little a. Lipoprotein little a is essentially LDL cholesterol with an additional protein called apolipoprotein A attached. And this extra protein makes lipoprotein little a particularly dangerous, because it not only clogs arteries, but it also promotes inflammation. It's like a double whammy thing. It promotes inflammation and clotting as well. And elevated numbers of lipoprotein little a increase the risk of coronary artery disease by 2 to 4 times. Okay. Now, probably less than 10%, like I said, of doctors out there are ever testing for lipoprotein little a. In this person, his numbers on lipoprotein little a are quite elevated. His number is 192. And you really want to have a target of less than 30. Okay, so lipoprotein little a is extremely elevated in this person. So the point I'm trying to make here is, if you didn't look for this, you would think that this guy was completely normal and you didn't really have to do anything for the next, 20 years. You wouldn't deal with any of this in a sort of, you wouldn't feel like you needed to make any really aggressive intervention. But the reality is, with a lipoprotein little a that is highly elevated, you now have to look at this as somebody in a completely different risk level by stratification. This is now a high risk person. Okay, so in a high risk person in particular, you really want to optimize the ApoB as much as possible, right? So this is a person that, in my opinion, really should be on maximal therapy to lower that ApoB number. Now, that could be through statins, but also through other drugs that we've talked about. Statins, of course, are the most common, but there are also ones called PCSK9 inhibitors, and those are extremely powerful injectable drugs that work very well at reducing cholesterol levels, and they're usually given to people who do not tolerate statins. But it's one of those things that hopefully you can, if you can avoid a statin, go to a PCSK9 inhibitor. That's personally what I would prefer. There's another drug called ezetimibe or Zetia, which actually can lower the amount of cholesterol that's absorbed through the gut as well. So I would probably likely want this person on that as well. The point being, I'd want to decrease that APO-B as much as possible because we have high risk here just by the nature of the fact that the lipoprotein little a is elevated. Now, what do we do about the lipoprotein A being elevated? Well, this is the tricky part, right? Because why is the lipoprotein little a elevated in this person in the first place? It's genetic. Okay. That's the thing. If you test for lipoprotein little a and it's not elevated in you, you never have to test for it again. You don't have the genotype that creates high levels of lipoprotein little a. It can be as simple as not testing for it again once you know you don't have it. No, of course, in this person, it is elevated. And so until very recently, the only thing you could do is optimize every possible other thing around, basically really suppressing APO-B as much as possible and all that, and hope that you could, not have the additional risk of the lipoprotein little a bite you in the ass. Now, the good news is there are several emerging therapies, like one called pelacarsen, that's Pelacarsen. And this is what's called an antisense oligonucleotide. And basically what that does is it targets the genetic instructions for producing lipoprotein little a, and it prevents it from turning into a protein. It basically blocks the expression of that gene, basically from, creating its product that it would normally create, which in this case is lipoprotein little a. And by doing that, it can reduce levels of lipoprotein little a up to 80% in some of these clinical trials we're seeing. So in this patient who has a lipoprotein little a of 192, that could literally be a lifesaver. Again, I'm not doing these breakdowns in any way to say that doctors are not, that they're not doing you justice, they're not working hard or whatever. That's just not the case. These things that I'm talking about today are things that I didn't learn about in medical school. Okay. They just weren't. And most doctors in practice right now, they're like my age, right? Like they're not super young, right? And I don't even know if they're teaching this stuff necessarily in medical school right now. They probably are a little bit. I'm guessing they are. But the point is there's an entire multiple generations of doctors who've never heard of any of this. And again, going back to earlier, if all you did was look at this guy's LDL and triglycerides and you thought, well, God, he's an active guy and not much to worry about there, you'd probably just leave it alone by traditional measures. But you go one layer deeper and you start doing some of these additional tests, like we do, as part of our part of our course and our coaching program, you can uncover potential landmines. I mean, I really think if we deal with this situation aggressively, we should be able to seriously eliminate, or at least significantly mitigate significant cardiovascular disease risk, in the next 10 to 20 years for this gentleman. So just to be complete, the other thing that we did note was that he does have some low grade sort of inflammation. What I like to test for that is something called high sensitivity CRP. And basically what it tells you is, how much sort of low grade inflammation there is. And HSCRP seems to be the one that you want to typically test to find the stuff that might affect the heart more than other kinds of inflammation. So the traditional value is, to keep this under 3 milligrams per liter, and that is so-called normal. But the reality is anything above 1 is elevated. And in this guy, it's 1.2, not a huge amount of elevation there, but we really want that to be, in his case, I would want it personally. If it were me, I'd want it, closer to about 0.5 milligrams per liter. So, um, again, why? Because there's two parts that we know of that result, two components that result in coronary artery disease, cardiovascular disease, that is elevated lipids and inflammation. So if we attack both of those and keep those controlled, it gives us the best chance of not dying from this thing, which is the most common killer of in humanity. So what can you do about an elevated HSCRP? Well, you certainly can get elevations in low-grade inflammation like this if you have some level of metabolic syndrome. So we're not going to go through the entire history here, but that's one of the things you would really want to focus on. Is you would really want to optimize your metabolic health. You check for insulin sensitivity. Try to get a fasting insulin targeting 3.5 or less. And then, hopefully that brings it down. But if not, there's other ways to consider doing that. Certain supplements like fish oil, for example, can help with some of this inflammation. And in another way to do it, and one that I actually personally do as well, is I take low dose colchicine. Now, this is very unorthodox. And the only ones I know who really prescribe this are really cutting edge cardiologists, because there is this literature that basically shows that if you treat patients who've had heart attacks with colchicine, keep their inflammation down, they're much less likely to have a second heart attack. In fact, it becomes a bigger factor. Inflammation becomes a bigger factor for second heart attack than even LDL levels. So personally, if I was this gentleman, I would also want someone to prescribe me low dose colchicine, and try to bring down my HSCRP. And at the same time, I would continue to work on trying to optimize my metabolic health. In case you're wondering, if you like to get into the weeds, the study that I'm talking about that relates to colchicine, it's called the COLCOT trial, COLCOT. And what it demonstrated that colchicine lowered HSCRP levels and reduced the risk of myocardial infarction, which is a heart attack, in patients with a history of heart disease. So for a patient with elevated lipoprotein a and APO-B, this could be a really valuable addition to the prevention strategy. Anyway, hopefully these case studies are providing value. There are also things that, if you take the course and if you get into, coaching sessions with me, and also down the line when we start doing some of our group sessions, you will understand. And it's stuff that I feel like you really need to understand if you are going to really take control of your health and optimize both your health span and your lifespan. The thing is that to think about here is that when we're talking, what I'm realizing too is that, we sit there and we talk about supplements and we talk about interventions like saunas and red light and all this stuff. But the reality is all of those are incrementally adding health span and lifespan. This is what we're talking about is bread and butter here. If you can avoid coronary artery disease because you acted aggressively early on, rather than, have a heart attack or have a bypass and deal with that later, that is going to significantly improve not only how long you live, but the quality of your life. Hopefully, I'd love to work with more of you. If you're interested, go to longevityroadmap.com and sign up. And that's it for this week. Next week, we'll go back to some other kinds of longevity talk as we interview some really interesting people in the coming months here. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe.